Hello, everyone, and welcome. I'm John Lynn, the founder and chief editor at Healthcare IT Today. And we're excited to have really an expert and a thought leader in the health IT industry with us today. It's Micky Tripathi. He's former CEO of Massachusetts eHealth Collaborative, and now he's the chief alliance officer at Arcadia.io. Welcome, Micky.
Thanks, John. Really delighted to be here.
Yeah, well, I mean, we've met a lot of times over the years, so I've always appreciated your insights and glad we can bring them to our audience. But, you know, the big news that came out recently was that the collaborative that you were CEO of is really winding down its operations. It was a nonprofit, I believe, and so, you know, that's an interesting, different than a business, I think, winding down the operations of a nonprofit. But you're also transferring some of the assets to Arcadia. So tell us about what went into this decision to wind down the collaborative.
Yeah, sure. Well, I really appreciate you reaching out and appreciate the interest. So thank you. Yeah, so we were founded in 2004 as a nonprofit collaborative, originally to run some pilot projects that Blue Cross Blue Shield of Massachusetts had put some money up for. So there was, one of the things that is always hard now. Here we are in 2020. But you have to project yourself back to 2004 and realize back then we had no idea, as you recall, how we were going to get people to adopt electronic health records, right? And it was like, 10% of providers had them, and half of those were, my brother-in-law's Access database, which I swear is the greatest EMR in the world. And so Blue Cross Blue Shield, decided with working with the Massachusetts Medical Society as well as the Massachusetts chapter of the American College of Physicians, they decided they were going to put $50 million into sort of a community pot to fund essentially some pilot projects to really, sort of see if they could push forward in Massachusetts at least a common understanding of what are the benefits, what are the costs, what does it take to get electronic health records adopted at scale. And one of the reasons that they did that was because again, as you may recall, there was really a stalemate back then about who actually benefits from electronic medical records, which is why we were seeing a lot of underinvestment in it. Right? Providers, doctors and hospitals felt like we're being asked to make all the investment, but everyone else benefits and we don't. The payers benefit, patients benefit, labs benefit, everyone benefits, but we don't. So we're not going to invest, because we're not getting any of the benefit. So Blue Cross was willing to say, you know what, we might be willing to think about some kind of cost sharing here. But let's do an experiment. So anyway, fast forward, they put up $50 million. That was the launching of the collaborative. They decided Blue Cross was very adamant that it needed to be a community project, not a Blue Cross project. So they helped to inspire the founding of this nonprofit collaborative. And I was fortunate enough to be selected to be the CEO. And then we launched these pilot projects, which we ran for 3 years. Well, I guess it's like 4 years, from 2005 to 2009. And those were, it involved 600 clinicians, 4 hospitals across 3 markets in Massachusetts. And what we did is we paid for electronic health record systems, health information exchange technology in each of the 3 markets, and a clinical quality data and warehouse and analytics service on top of all of that. So you had sort of 3 layers. And so then, that was a nonprofit, kind of pilot project, and we ran those pilot projects, and everyone was very happy with the results, and we learned a ton of lessons that we, tried to share both in Massachusetts as well as with the market at large. And then in 2009, as we were thinking about, well, the pilot projects are done, maybe we should wind down the collaborative because, the job well done, right? It was just a project, and that's what we were there for. And I was, perfectly prepared to say, let's move on to the next thing. But one of the things that happened right around then, you may recall, is the economy crashed. We had the American Recovery and Reinvestment Act, and we had high tech, and all of a sudden we had meaningful use and $30 billion behind that, right? And all of a sudden, the board sort of slammed on the brakes and said, all right, time out. Let's just think about this for a second. And we started getting market demand for the kind of capabilities that we had built, which I can talk about, a little bit later. And so that was when we decided, all right, we're going to pivot, and we will now become just a fee-based service organization. But because so much of the money was in support of meaningful use and all of those, sort of community health goals that that were hired behind, the HITECH Act. We felt very confident that, that we were still fulfilling a nonprofit mission. So we kept the organization as a nonprofit, even though at the time we thought, well, maybe we should flip to for-profit. But again, we were doing mostly work that was, rooted back in government funding for this, this nationwide, sort of investment to move all providers forward to improve health at large. So
yeah, let me stop you there for a second. I mean, it's just fascinating to think that you are buying EHR for the practices in order to facilitate the interoperability, right? Like, I mean, now we would almost be like, it would be a joke to pay for the EHR now.
Right,
I mean,
right.
we often say, well, what came of the $36 billion of HITECH Act money, right? And you're like, well, the answer is now you can do interoperability and you don't have to pay the doctor for their EHR, which
right. No, absolutely. I mean, I think I think you're absolutely right, because one of the things, that we we're always sort of in this situation of saying, oh, we're so behind in interoperability, but you can't have interoperability until people have electronic health records. I mean, you can't have phone network if people don't have phones. So, so I think that was just a fundamental piece of it, that it's now, and as we think about, where are we headed in the future, the nice thing is we've got that foundation laid now, and we can start to think about what are the things that we can do on top of that.
Yeah, and let's talk about some of the things you guys did accomplish, and then we can, move forward to the Arcadia move as well. But, you guys were even the REC, if I remember right, for it, right, to help implement. So, I mean, you did the REC, you did interoperability. What were some of the big accomplishments that you're really proud of that the collaborative was able to accomplish?
Yeah, so I guess I would point to a few things. One is that we learned some lessons really early that were painful lessons that ended up becoming things that got that got incorporated in the Meaningful Use program, the national program. Because if you go back to when we were doing this, we were the only activity that was doing this at scale across a community in the country. I mean, it seems funny to think about it again. Now, of course, Kaiser was making their large investment in Epic at the time, and you had different organizations within, integrated delivery networks and hospitals making those investments. But, in 2004, 2005, we were the only ones doing this at scale. And actually, it's a funny coincidence that, David Brailer, who was the first national coordinator, we invited him to come up for our kickoff, which he did. He was gracious enough to fly up for our kickoff. And one of the things he joked about was that you may remember, the first budget he had was $52 million, and we had 50 for the entire country, and we had $50 million for 3 markets in Massachusetts. And at the time, Congress was holding up his money as well. And so one of the things that he joked about when he was up here is, he said, I really want to see, talk to the people who are actually going to be able to accomplish something and who actually are going to be able to spend the money. So some of the lessons that we learned, very early on, were that, one, first and foremost, that, this actually is something that has to be actively managed, particularly among small practices. And that was really, you can follow sort of a direct thread from those lessons to the Regional Extension Center program, because, early on, we went out, we hired a vendor to do the hardware installation at all the practices, and then we hired software vendors, EHR software vendors. And then, our thought was, okay, we're going to be a very highly leveraged organization. Small staff, we'll manage these vendors, we'll make sure they're meeting their milestones, and then that'll be it. And so we launched 5 to 7 pilots across these 3 markets, and it was a disaster. And it was an absolute disaster. There was no coordination. You had these different people just showing up at the practice. No one knew how it all fit together. The software vendor, of course, felt like the hardware vendor was supposed to do everything. The hardware vendor felt like software vendor. Both of them thought that the practice should be doing more. And we were nowhere to be found, right? Because we thought, well, the vendors are going to do that all. We're paying them a lot of money. And so one of the lessons that we learned, and one of the funny stories back then is my father is a physician in Massachusetts, and when we launched those 5 to 7 practices, the hard part wasn't that they called my board chair to say, hey, this is really bad. They were calling my father. These doctors were literally calling my father and saying, your son is a good boy, but boy, is he screwing up here. So anyway, my father was calling and saying, what is going on? But anyway, so one of the very early lessons was, we stopped it at the end of those first pilots and said, all right, we need to rethink this entire thing, and went back to the board and said, we're going to have to staff up to create a support organization that is actually going to project manage every one of these 200 installs, because it was 600 clinicians. They were in 200 sites across these 3 markets. And we said, we're the ones who are going to have to own that. So at the end of the day, we have single point accountability, so I can look that doctor in the eye and say, I'm responsible. Not eClinicalWorks, not Allscripts, not the hardware vendor. I'm responsible at the end of the day, and it's our job to make sure all these vendors are working. So that ended up becoming a lesson learned that that New York City ended up adopting when Farzad Mostashari and Matt Kendall were, in New York City. They got $20 million from Mayor Bloomberg, the city, not Mayor Bloomberg, but from the city to do a similar large-scale experiment. And they came up to Massachusetts, and we talked a lot about the lessons learned that we had. And one of them was about building a support team. Farzad and Matt, of course, then went to the National Coordinator's office and ended up, creating the blueprint with the Regional Extension Center and a whole bunch of the other things that, that were lessons learned there. So that was one of the things that, was a lesson learned. The second thing is, if you look back at when you were talking about the money that you were talking about, if you look back at the amount of money that we spent, actually. So at the end of the day, there was always a question of, how much is this going to cost? How do we even figure out what this is going to cost? That was one of the things that Blue Cross wanted to, sort of answer. And so one of the things that we did is we provided, we did a complete accounting of how much it cost per doctor for every single piece of it: hardware, software, training, support, all of that, and came up with a number that it cost us about $37,000 per provider to get this done. That was going to be the cost that a provider would have to pay if he or she was going to do this on their own. When you fast forward, look at the Meaningful Use program, what were the numbers that they ended up providing? It was $35,000 to $40,000, and maybe up to $60,000 if you're a health center, but it was right in that range. I think, again, drawing directly from those lessons learned that helped inform how do we do this at scale across the country. So as I said, a couple of things that we really wanted to accomplish at the beginning was, how do we inform the industry and the community about how you get this done? And that's, part of what I'm really proud of, that we're able to sort of offer some lessons that people were then able to jump on and take. The other thing I would point to is, once we got past the pilot projects, we were able to help other markets, HIE organizations, other provider organizations across the country with writing their plans for statewide HIEs, for example, with helping them with vendor selection, and a variety of other things that we were able to do under a nonprofit umbrella that gave us a lot of trust. That again, I think, helped to offer a lot of value to those organizations, I think, and to accelerate their learning, since we at least had one big experience under our belt, which was one more than everyone else had. And then I guess the last thing was our lessons learned around standards that help to inform things like, ultimately, contributions to the HIT Policy Committee, the HIT Standards Committee, because we had gone through all of the muck of consent, technical standards for, connecting up EHR systems. How do you, do that appropriately in a live health information exchange? And then how do you extract that information out into a data warehouse where you can then run analytics on those and calculate clinical quality measures? We were doing all of that in 2007 in very primitive and crude ways. But I think, we also were able to, by participating in those national level policy organizations, at least provide the on the ground experience that we had, that helped inform that, at least, with some real market experience that hopefully made that better than it otherwise would have been.
Well, and it seems like you have been at the core of the interoperability. It's interesting. I knew some of the implementation stuff, but I didn't realize the whole background. But you definitely have created a name and been part of that whole standards and interoperability. Is that one of the things you still haven't fully accomplished, or what are some of the things that you wish you would have accomplished more and still need to be done?
Yeah, I'm not sure. I mean, you can always go back and say, boy, there's a whole bunch of things that we could have done, better. I'm not sure that, that knowing what we knew, I'm not sure, how many of those things we wouldn't have just made the same mistakes all over again. But I guess, some of the things that I think that, that might have focused more on, if I think about the MAeHC Collaborative itself, we probably would have focused more on driving quality outcomes more than we did. We were so focused on, can we just get these systems into the hands of providers and have them using them? That'll be mission accomplished, right? And so we did have, another thing that we had that was interesting and sort of had a direct path to the idea of meaningful use was the contracts we had with those providers, because we were paying for everything, right? So it was completely free to them. Well, of course, they had a lot of skin in the game because they were the ones who had to adopt it, and they had revenue loss and all those things, but they didn't have to pay for the hardware, the software, or the staff. But one of the things we put into the contract is what we called our use criteria, which was, you're getting these systems for free. Here are the things you have to do. You have to e-prescribe. You have to get electronic lab results delivery. You have to document in your system. You have to enter structured problems. So again, an interesting sort of precursor to what meaningful use ended up becoming. So I think that, but we didn't focus as much as, in hindsight, I would have liked to have done in the way of quality, saying how do we push forward to get better quality measurement and help people understand how you can use the systems to improve quality and efficiency in a much more sort of focused way. With respect to the lessons learned as we think about interoperability and where we are now and where we have to go, I'm not sure. In hindsight, again, there's been a lot of criticism that that we should have pushed interoperability sooner in the meaningful use program, right? That, boy, here we are, we're still here. These systems aren't as interoperable as we thought they would be, and all of that. But again, I think if you follow, the meaningful use trajectory of phase 1, phase 2, phase 3, it was very deliberate to sort of say, first you have to get people just to adopt the systems. I mean, they have to be able to use those systems before you start thinking about how you're going to connect them up. Because they can't even figure out how to use the systems in their own office, let alone sort of all of the complexity that comes around consent and sharing of records across state lines and all of that stuff that was really complicated. So I'm not sure that that the phasing was a mistake. I think that perhaps we could have sort of focused a little bit more on perhaps that it came a little bit later in the process when direct. And the notion of sort of understanding push versus pull and the ability to unpack interoperability. So it may be that in hindsight we might not have spent the $700 million that we did on state HIE programs. That each state got a certain amount of money to create a statewide HIE. Very few of those, I think, have ended up in sustainable HIEs that you can trace back. I mean, the ones that are still up and running are the ones that were successful before, right? Rhode Island, Cincinnati, Indianapolis, a couple of others. Most of those were already around. Nehan in Massachusetts, they were already around. They were able to benefit from the money, but now they continue. I think that. But there were still lots of lessons that were learned from that too. So when I think back on that, I think of it as, well, maybe it was $700 million that wasn't spent on creating nationwide interoperability in the way that we had thought about it at the time, but it was a very valuable experiment in basic research on what are the complexities of HIE, how do we think about consent policy, how do we think about the ways of getting adoption, who are the different stakeholders that you need to have participate to make HIE work, and I think all of those lessons were lessons that helped to propel Commonwealth and care quality in the nationwide networks that we have today. Hopefully, I think in a way that is faster and better than would have been if we hadn't spent that money on these state level experiments.
Yeah. And I think it's interesting your comments about focusing on maybe some meaningful measures sooner and the impact on how to use EHR to do that. But I think people have this revisionist history in their head because back, I started blogging essentially the same time as you, about a year after. I'm 15 years at the end of this year, and so I went through the same cycle you did, right? And back then, the goal was, how do I upcode? right? Like it wasn't how am I interoperable? If I adopted an EHR, it was because I wanted to be able to not even upcode because that's a legal term, right? But I wanted to be able to code at the level of care I was giving, but I was unable to document in the patient chart. And that was the discussion. That was the financial driver. It wasn't let me adopt an EHR to improve care and to get records from other organizations. I mean, that was like a further thought from their head, right? And so like, even someone who says, oh, meaningful use was meant to drive interoperability, it's like, no, it was meant to adopt the EHR. And then I would add one other layer, which is interesting, is we take for granted the benefits of being able to read the chart, being able to quickly access the chart, right? Like those are things that are incredible benefits of an EHR. And as soon as they happen, we just assume, oh yeah, of course, that's how it always works. And I guess that's really where now, as you look forward and you move to Arcadia, why was that a good fit for you going forward with them? And what else is there still to be done as you move into this new position at Arcadia?
Sure. Yeah. So the MAeHC Collaborative, we, as I said, we launched it in 2004, late 2004, and I had assumed it was going to be like a 5-year thing, right? Probably less, as I described. And then here we were 15 years later, still running this nonprofit, and a couple of things happened that made it very clear to me and the board that it was time to transition the organization. So one of them was just that we were operating as a nonprofit, and operating as a nonprofit in very good faith over that entire period of time. But we were getting to the point that we had a for-profit subsidiary, so we were able to take in for-profit fees, and then we would pay taxes at the end of the year on things that were that were genuinely for-profit. So we had that model, but we started to get a higher and higher fraction of our revenues were from the for-profit side, to the point that it was something like 70% as we were going that, and that looked like it was steady state. Now we had these issues in the past, but it always had flipped around, and so we were always able to discuss with our attorneys and discuss with our accountants that no, you're not, you're still not in an issue where it violates your nonprofit mission, because these things are going up and down, and there seems to still be a lot of nonprofit community health oriented kind of work out there. But now, as we look ahead, right, it's very clear we're not going to have another meaningful use. We're not going to have these kinds of public dollars or public oriented dollars coming. So we discussed with the board. All right, it's very much time for us to now convert the organization to a different corporate model. We want to do this ahead of when we don't want the IRS telling us that we have to do this. All right, we're a good citizen. We want to do this because it's the right thing
That's
to do.
Good. So why Arcadia?
Yeah, so with Arcadia, so what we did is we decided that that we also decided that we weren't going to try to go out on our own, right? Because that's the other thing we could have done, is say, well, why don't we just flip it to a for-profit? We'll go out and raise money and talk to a bunch of bankers, and and we'll do that. And if we were doing that 6-7 years ago, maybe that would have been a good idea. But now the market's really different, right? I mean, there are tons of startups out there, a lot of competition. That's great, right? That's an ecosystem. And we are not, we are not the kind of organization that would have competed well, I think, as, we had nonprofit mission in our roots. So it's like, that's not going to really work real well for us to try to go compete for VC dollars and try to change the fundamental culture of the organization. So that's when we said, all right, it makes sense for us to transition to a larger organization that can help us, sort of take everything that we've done and incorporate that, and even, hopefully help them move forward. So we did some diligence around a few companies that we thought were aligned with us culturally, because that was really important. And we had 20 employees. We wanted to make sure that it was going to be a good fit for us, and that it was a graceful transition for the collaborative. And then we ended up, talking to Arcadia most closely for a number of reasons. One is they're a Massachusetts-based company, and we had worked with them for a number of years, actually, as sort of somewhat competitors, but we also had some common customers that had us working together side by side. So we had a good feel for the organization, and they do a lot of things that were the kinds of things that we were headed toward, which was we had this data analytics business, and more of our business was headed in the data analytics space. And Arcadia is a technology vendor first and foremost, and they've got a population health management solution, which was very sort of complementary in some ways to the kinds of capabilities that we had built and where we wanted to go. So that's what made it a really good fit. I think is from a mission perspective, it was a nice fit for where our business was headed. From a cultural perspective, Arcadia is very mission oriented, focused on value-based purchasing, value-based care, and driving, helping organizations, drive higher quality and greater efficiency in population health in general. So that was a nice fit as well, and the fact that it was a Massachusetts company was really was pretty important to us. Most of the headquarters are here in Burlington, Mass, and our roots are in Massachusetts. They have a big Massachusetts customer base, and so a lot of the organizations who were our customers were Arcadia customers or transitioned to being Arcadia customers, which helped with the transition as well.
Yeah, and it makes sense from a staff perspective, because if you live in Massachusetts, you want to live there. That's what I found.
Yeah, there was a lot of opportunity. The nice thing is for a lot of the team, Arcadia being a bigger, more sophisticated organization from a technology perspective and from a business perspective, opened up a lot of opportunities that people wanted to have, but were a little bit stifled because we were a 20-person nonprofit shop. Right, but Arcadia is is a large organization and a leading technology vendor in the population health management space. So and leading on the technical side as well. So that opened up a lot of opportunities for people, which was great. And it's been a really great transition.
That's great. Well, we're going to have you back to talk population health in Arcadia, especially as you immerse yourself into it. But it also seems inappropriate if we don't mention COVID-19 in an interview. So before we wrap up, you're kind of a leader in healthcare interoperability. You've been on a lot of the committees, a lot of the progress around standards, a lot of different things. So what's your take on COVID-19 and interoperability? In some ways, it seems to have really shown a spotlight on why we need it, and also it's shined a spotlight on the fact that we don't have it yet. But what's your take on it?
Yeah, I mean, I think a couple of things. One is that so there's no national strategy around any of this, right? So and that always just makes it challenging, right? If we don't have a national strategy, it's really hard to figure out, what it is you want to do and how do you make these pieces fit together, because, interoperability in some ways, isn't that different than other parts of the U.S. economy, which is very decentralized, right? So, that's one of the challenges. But I think, as we think back on why is the infrastructure that we spend $30 billion on not delivering the kinds of information and the kinds of capabilities that we would want to be able to help us through this tragic pandemic, right? I think that's the question you're getting at. One big part of that is we didn't have meaningful use for public health, right? So we put all of the provider organizations on steroids by giving them these sophisticated EHR systems, told them that you have to send all this data to public health, but 56 different public health organizations in the states and territories, right? So every one of them literally had different lab standards, different versions of HL7V2, and the CDC and the federal government didn't have the ability to supersede the local autonomy that each of those states had. So you still had a patchwork, even though you had public health reporting, ELR, electronic lab reporting, syndromic surveillance, registry reporting, all of that happening in all these different states out of these EHR systems, but all of it a patchwork, none of it really actionable because we couldn't put it together in a way that would make sense to be able to solve the problems we have. And because we had the meaningful use for the providers, we were able to send the data to public health, but we didn't give them any resources to do anything with that data, right? So you literally had data just flowing and filling up these legacy, very old software COBOL-based systems in these departments of public health. And this isn't their fault, right? I mean, they're dealing with the resources that they had, and so they had no ability to really act on that and do the kinds of things that we want to be able to do now. I mean, I think when we look back, I think we're going to realize that part of the tragedy was that we didn't spend a bunch of those dollars on public health, and literally zero of those dollars went to public health, and that's one of the big gaps and the mismatches that we see today. I think we are seeing now, that one benefit of having had that investment in electronic health records, though, is we have nationwide event notification services that are now companies like Patient Ping, for example, that are able to, and Commonwealth is moving into providing these kinds of ENS services as well. That you have the ability, because you have those systems, to be able to get ADT information and now start to be able to at least have better tracking and better capability of understanding what's going on in all those systems. That'll unfortunately not be enormously helpful. I mean, it's somewhat helpful for where we are today, market by market, but it's not a truly national system. And unfortunately, that'll help us in the next pandemic, not quite as helpful in this pandemic, I fear. I think there are probably other things that we'll learn are being done, with the EHR systems and with the interoperability that we have in place that aren't getting highlighted. But I think that right now people are too heads down to know that. So, for example, Commonwealth and Care Quality, I think, as you know, exchange millions and millions of CCD records across provider organizations today. I mean, that's all live, and and it's being exchanged today. But those are post-encounter medical records. As we know, there's been so many different changes in care, right? People not going into into office visits. So it's one of the weird perversities that that in cases where people aren't actually making visits to provider organizations, interoperability doesn't help you with that. There are actually no records to do anything with. So that's a little bit of the sort of funny part of the odd part of the situation that we're in as well.
Yeah, and as your neighbor, Dr. Dirk Stanley, who I think you probably know, CMIO, he wrote a great article outlining. I think there was 5 places you can find out if someone has COVID-19 in the medical record, which is another example of lack of standardization. It could be in the chief complaint, it could be in the lab result, it could be like there was all these options, and so it's not as easy as saying, well, the HR should just report on it. That said, I think we could do better than the Excel spreadsheet email that was offered by CDC as well. So. Yeah,
I think that's right. I mean, and some of the things that we're asking for are novel types of data too. So that's a little bit of a challenge as well. So we're, we tried, very hard till we've got the CCDS, now the US CDI, which defines 24, 25 data elements that would have to be standardized in either in a CCD or in a FHIR API. So that's all there. But guess what? When you actually want to really understand what's going on with respect to treatment of COVID, acuity, severity, the different types of treatments that are being used, the different types of devices that are being used, ventilator status, ICU capacity, all of those things, those aren't in the US CDI, right? So now if you want to get those things out of systems, Commonwealth and Care Quality aren't going to be able to help you with the CCDs they exchange today. So the COVID-19 coalition, one of the things that they did, and this is our system is is patchwork but has different layers. And so one of the things that's happened with with the EHR market is there's been a little bit more consolidation that's happened over time, right? And you may have seen with the COVID-19 coalition, one of the things that they were able to do was work with Cerner and Epic, who make up a large fraction of the hospital market. And get them to agree on a common standard for data extraction out of their EHR systems. And so in each of those systems now, provider organizations can work with their vendor to be able to run a local query on the on their instance of their EHR, and then be able to deliver that data to the Mayo Clinic is aggregating that data to run the research study on I think it's convalescent plasma, but there's other kinds of things like that that they're just able to leverage the national scale that we have with with some of the EHR vendors. Again, you would think, well, gee, couldn't an interoperability network have done that? The problem is that you're asking for data that isn't a part of the standard data that those interoperability networks were built to work with. So you have to work with the individual EHR vendors to try to get them to do more with the with the systems. And fortunately, Epic and Cerner were able to very quickly step up and do that at scale. So that's, I think one of those exciting things that I think hopefully we'll hear more about once we start to see that data get aggregated and used in positive ways to help us get through this.
Yeah, definitely. And I mean, there's a lot of other ones too. I don't know if you've seen the Saner project that Keith Boone, for a motorcycle guy on
Yes,
Twitter.
absolutely.
There's some others, like you said, ICU beds. There's no standard for that, and so I
Right.
think that's a bit. So
Everything about Saner was more about like a supply chain kind of thing, right? It was saying, let's not deal with clinical things, but how do we just understand our hospital and ICU bed capacity as a supply chain phenomenon? So that was tremendous work on, again, the types of data that you normally wouldn't pull out of an EHR, and certainly isn't something that was standardized, prior to this. So hopefully that'll fast forward that work and have it be, production ready for the next pandemic.
well, and as you highlighted, the thing I maybe take away from this discussion most is how far we've come. From where you were when you started the collaborative to where we are now, the opportunities are there. Everyone pretty much has an EHR, and so there's such a big innovation opportunity that's available that before would have had layers of complexity. So thank you for your work, and thanks for sharing all your insights. Thanks for everyone for watching. If you want to find more great health IT content like this, check it out at healthcareittoday.com. Thanks, Mickey.
Great. Thanks so much, John. Thanks, everyone.